Well, while we wait for people to join us today, you might like to put in the chat function where you're joining us from, just to open that up, because we'll be inviting questions from our viewers, and we'll very much look forward to addressing those. Well, good afternoon. I'm Professor Andrew Bonney. I'm a general practitioner and Roberta Williams Chair of General Practice at the University of Wollongong. And it's a pleasure to welcome each and every one of you here today. So this series, the Luminaries series, brings together leading University of Wollongong researchers, industry experts and thought leaders from across Australia for a 1-hour conversation every fortnight. And we'll discover how research and collaboration from the University of Wollongong and all of our collaborators and friends and partners across the nation are tackling global challenges. And today we're going to hear from a group of exceptional colleagues as we discuss the future of rural generalist healthcare. But before we start, I'd like to acknowledge country. So on behalf of the university, I would like to acknowledge that country for Aboriginal peoples is an interconnected set of ancient and sophisticated relationships. The University of Wollongong spreads across many interrelated Aboriginal countries that are bound by this sacred landscape and intimate relationship with that landscape since creation. So from Sydney to the Southern Highlands, from the South Coast, out to the South Coast, from freshwater to bitter water to salt, from city to urban to rural, the University of Wollongong acknowledges the custodianship of the Aboriginal peoples of this place and space that has kept alive the relationship between all living things. And the university acknowledges the devastating impact of colonisation on our campus's footprint, and we commit ourselves to truth-telling, healing and education. Well, thank you and welcome. Well, we've got a star-studded panel this afternoon to discuss a topic that's been particularly prominent in recent media in the last while, and that's around rural healthcare. We know that retaining rural healthcare workers in rural areas is crucial for the care of those communities, for continuity of care, for ensuring access to care, improving health outcomes in rural communities. And we know that factors such as stress and burnout and pre-existing pressures within the health system have adversely affected that workforce, and those pressures have only increased in recent years. So this webinar explores current health workforce distribution to meet the needs of communities. We're going to look at some emerging research on medical education models, training models to address those challenges, and the opinions and thoughts of our national leaders here with us today. So it's my pleasure to welcome our panel. That includes Professor Richard Murray, who has a career focused on rural medicine, Aboriginal health, tropical health, and socially accountable health and professional education. And Richard probably doesn't realise, but I used his and Sophie Kouzos's book as my textbook when I was engaged in Aboriginal health back in the 1990s. So Richard's been very influential in my career over the time, and the career of many, many others, I'm sure. So he's a medical practitioner with qualifications in rural general practice and public health, and he's Dean of the College of Medicine and Dentistry at James Cook University. And Richard also, in his spare time, is President and Chair of the Board of Medical Deans of Australia and New Zealand. We've also got Professor Charlotte Hespe, who is a GP and practice owner in inner Sydney, and she's the head of general practice and primary care research at the University of Notre in New South Wales. And she's also the current chair of the RACGP, that's the Royal Australian College of General Practitioners, New South Wales and ACT faculty. Amongst many roles, she's also chaired GP Synergy, which until this year was the regional training provider for all of the New South Wales and ACT GP training program, which included both the College of GPs and also the Australian College of Rural and Remote Medicine Pathways. She was also founding director and chair for Central and Eastern Sydney Primary Health Network in 2016, after chairing the Inner West Medicare Local from 2012 to 2015. We're also joined by Dr. Rod Martin, who's a rural generalist in Armidale, and we're going to talk somewhat, I'm hoping, Rod, about rural generalists and rural general practitioners and the roles, complementary roles that those two professional locations provide to each other. Rod has responsibilities in general practice, emergency, anaesthetics and obstetrics. He teaches and supervises medical students, registrars and consultants, and a number of training courses and curricula. Rod is the New South Wales representative on the Australian College of Rural and Remote Medicine. So welcome, Rod. And Professor Zsuzsoka Kecskes is Dean of the Graduate School of Medicine at the University of Wollongong. She also holds honorary professor status with the ANU Medical School, and her main research interest is in neonatal, the neonatal brain. Lately, she's been focusing on quality and safety assessment and education, and is intrinsic to our training of future rural practitioners at the University of Wollongong. So what I encourage is members of the audience submit their own questions using the Q&A function, which I've got open here. And you can either address those general leads or to members of the panel. And we'll try to get through as many questions as possible. So let's just launch into our first set of questions. I'm going to address these particularly to Rod and Charlotte, or Charlotte and Rod, whichever way you would like to organise that. So let's just kick off with a discussion around rural medical workforce. And so the shortages have been reported frequently in the media. And what's frequently missing in the discussion is an appreciation of the difference in the healthcare models between urban and rural areas, because, you know, whilst people's healthcare needs differ somewhat in their distribution in rural areas, the healthcare models are also quite different as well. And generalist roles are much more prominent in rural communities than they are in urban communities. So Charlotte and Rod, can I ask you first about the roles of generalist doctors in rural areas and the kinds of training they need? I might start with Charlotte as a starting off point, and then I'll come back to Rod if that's okay. So let's have a talk about roles of generalist doctors in rural areas and training needs, Charlotte.
Thanks, Andrew. Look, for me, get me onto the passion about generalism. Generalism is actually the foundation of the healthcare system for Australia. So it is actually an urban need and not just a rural need, can I say? And I think that we sometimes get lost in saying that GPs who are true generalists aren't a part of the functionality of our health system in the cities. It's easier to abrogate responsibilities, I suppose, if you are in a setting where there are other people who can do it. And obviously, when you're in a rural setting, you are far more likely to be the only medical practitioner available to provide a lot of those generalist services. And a good generalist, the joy of generalism is you are actually able to look after the whole person in front of you. Having said that, you know, the bigger the town you are, then there's more likely to be other people who can complement your skills. Because obviously, if you are an obstetrician, gynecologist, rural generalist who can do sort of more procedural care for your patients, you still need to have someone who can provide the anaesthetic support and someone else to provide the paediatric support, etc., alongside of you. So there's still this need to be part of a team. And I won't go into some of those nuances. What I can say is that rural generalism is still very attractive to the GP population broadly. And I can say that because I know we've got 9,000 members in the RACGP who are part of the rural faculty. So that's a good healthy number of people who identify with being able to provide work as a GP in a rural setting. Of those, though, if you sort of get down to those who've actually trained to be a rural generalist, we have 468 who are officially endorsed to be rural generalists, but that doesn't include those RACGP trainees who've done their FAR GP and haven't actually asked to be moved into being a rural generalist. And this year, we've had 129 applicants to sign up for rural journalism training under the RACGP. So they're not good enough numbers, one could say, but they're certainly healthy numbers. The biggest issue from my perspective, again, calling out maybe some of the elephant, is that what we don't want is rural generalists just going to big towns where they can be supported in a hospital. We actually need rural generalists to be across our entirety, because what we are seeing is gaps in care. And this is particularly poignant from the Royal Flying Doctors report, which is showing an increased number in Category 1 retrievals, and more worrying, increased morbidity mortality in women in rural areas due to lack of access to primary care services and in particular preventive care and screening. And so we know that the big issue is actually getting GPs into every locality that needs that. I was talking to Michael Clements, who's the chair of our rural faculty, and he quoted to me Mission Beach, which is a really popular town with tourists, yet it's got no GP, but the surrounding bigger towns that have got a hospital do. So we need to be able to make sure that rural generalists are supported to be everywhere and not just feel like supported in a town with a hospital.
That's
I'll
great.
hand over to Rod at that point.
Okay, thanks, Charlotte. So certainly there's people in the pipeline, and there's a variety of roles that need filling, and obviously generalism is very important across the country, but not just in rural areas. But you pointed out very nicely just the necessity for a generalist skill set in rural areas, but providing community-based primary care as well as hospital services. Well, might hand over to Rod, and Rod, your perspective on that, and also a little bit about what's involved in training for rural practice, and your thoughts in around that as well.
I'll take up Charlotte's last point about that, and your point about the pipeline that we've got. We have people coming along through the pipeline. At times, that pipeline gets a little bit leaky, and it's leaky in a few interesting and different ways. As Charlotte said, there's not a GP in Mission Beach, but there's plenty in the larger towns, and we've got this interesting, and I unfortunately refer to it as a bit of a perversion, where we now have, certainly in Queensland, they've got this situation where there's lots of these towns that have got really great rural generalists in hospital supply, but in exactly the same towns, they're struggling to get people to do the primary care work that still needs to be done. So I know there's a few towns in Queensland now that are trying to say, well, come as the rural generalist, bring the skill set that you want to bring and deliver, but just don't expect that you're going to be doing full-time emergency medicine, because that's not what this community needs. It's actually making sure that the skill set someone brings also comes along with that primary care capacity and that primary care skill set. That's what we assess towards. We had a little run for a while where everyone thought that if they wanted to do emergency medicine, they would come and do a FACRM, and lots of those people struggled to get through, because it's more than just emergency medicine. It's primary care and being able to do secondary care and understanding the public health responsibility that you have as a rural generalist, no matter where you are, even if you're not a public health physician. I guess the types of training and the expectations that I have, because I've been an examiner now for ACRM for, I guess, a few years now, probably 12 or so years now, and I guess one of the things that we have as an expectation, in addition to the location that people train in, to the skill set that they've specifically trained towards, is that they are able to manage most of the things in whichever town we would potentially, place them in if we were to do any placements. So that means that we expect that they can manage an emergency, but not to a FACEM level, but certainly keep control of the situation and stabilise the patient until they can maybe go to definitive care, or maybe they go to the ward. Similarly, we expect a rural generalist to be able to deliver the baby for the traveller that comes through town and all of a sudden ruptures their membranes and has the baby in town. So it's that breadth and depth that is the challenge. And that sort of married up with things like, clinical courage and some pretty good, robust clinical reasoning skills, some of the essential elements. I guess, again, from the way that we certainly assess some of our candidates, it's being able to have it that they have a pretty good and robust ambiguity tolerance as well. I know in medicine we very, we all have to have a reasonable ambiguity tolerance no matter what we're dealing with, but the ambiguity involved with, do I send this patient by helicopter somewhere or by plane, is a bit more focused. I used to call, when I was a registrar in a little town in central Queensland, I used to call it the 4 o'clock decision point. Can I tolerate having this patient in town here with me, and do I have what I need to be able to look after them for the next 24 hours with no pathology and only a couple of different x-ray views that I can do. And so having people ready for that sort of environment, in part by where they've trained and the language that they are continuously exposed to as an RG trainee, as well as how they get the pointy end of assessment, I guess is what fits people out, and make sure we will unashamedly not pass people if we don't think that they're ready for the communities that they work in, because it's also safe for those people as fellow doctors to wait another 6 months and be well and truly ready for what they need.
Okay, thanks Rod. So Rod and Charlotte's an excellent kind of summary of the kind of what's required and what is required of the people going there. But we also know it's not just more doctors overall, but an increase in the proportion of doctors choosing to work in rural areas, and it's an important area of research. And I might turn to Zsuzsoka and Richard now, both providing leadership in medical schools with a rural focus. And to pick your brains about what does current research tell us about models of medical education that seem to best address medical workforce needs. And I might start with Richard this time, if that's all right.
Oh, look, very happy to, and hello to my colleagues and all of those who are participating. Look, I think the evidence for what it takes to produce doctors who go rural has been accumulating now for a few decades, and Australia's made a significant contribution to that literature, but we're not alone. I think the best understanding these days is that it's really you have to take a complex systems lens. There's no single factor. It's not just about selecting students who themselves are of rural origin, notwithstanding that that's one of the most powerful predictors. It's not just about providing sufficient experiences and the rest of it. It's about the mix, the alchemy. That's our best understanding. And what are the ingredients? Well, the strongest predictors are rural origin students, non-metropolitan base of education and training. There's are probably the two, and the third is having available immediately beyond graduation local training pipelines into general practice or in the state's family medicine. So those are the big ones, but we know that all of these, the programs that are most successful and that are documented, their outcomes have lots of these features, including strong rural curriculum, role models, placement, longitudinal clerkships, student clubs. There's a whole package of these measures, and the most successful programs will have a lot of them, notwithstanding that 2 or 3 of them are the most predictive. So that's sort of the state of evidence briefly as I'd describe it. Look, I'll pause there. There's more to say, but
okay, thanks, Richard. And so, unfortunately, there's not a silver bullet there. There's a mix of things involved, and I guess that also then has a very geographical flavour to it, because how those components are mixed will depend on where the institution is, and you don't find universities in every nook and cranny of the country, and they all have different flavours and geographic footprints and so forth. So Zsuzsoka, from the perspective of where we are, University of Wollongong on the beautiful south coast of New South Wales. What's your take on what's required to help provide a rural health workforce?
Andrew, thank you. I'd just like to set the scene for everybody so you understand where I'm coming from and why Richard's evidence is so important. Medical schools aren't all the same. There are, first medical schools were established, I think, in the 1860s. So they're of different age. Some are undergrad, some are postgrad medical schools. They all have different visions and mission statements and whatever they're trying to achieve. And I think that's important to then be very clear on which medical school wants to achieve what and where the focus, I think, should be in terms of education and student placements. So if you take Charles Sturt, which is one of the youngest, I guess, medical schools still in their first few years, I mean, they only have rural focus in terms of placement, whereas, University of Melbourne and Sydney, being the oldest ones, have lots of hospitals that they can send students to for their placements. Medical schools also vary in what kind of students they take in. And you just heard Richard talk about, students from rural origin being those that are more likely to work in rural areas. And each medical school will have different criteria on which students to accept. The government gives medical schools money to train students rurally, with the idea that research and education will provide not just evidence, but also rural doctors. But again, each medical school will, not only get different sums of money, but will have different criteria on how many rural students to admit. So there's a whole hodgepodge of things that affect and drive medical schools, right? You've got Richard and me here, and we're probably two of the medical schools that have the strongest outcomes if you look at rural students, that continue to work in rural and regional areas, and even go so far that they would be rural and regional GPs or generalists. Whereas if you had somebody sitting from the University of Sydney or Melbourne, they would probably argue that there's a huge need of doctors as well in large tertiary institutions. So getting back to your question, what do we do? I guess what I'm saying is we can't treat all through the same lens. Government is, I think, trying to look at medical schools now in a different way and looking at what they call end-to-end program, where students are trained from beginning to the end, mainly in rural areas, and trying to support those medical schools in different ways and give them the kind of places, because I think there's a recognition that we have a workforce shortage. However, competition between medical schools for medical students, as well as for money, for research money and so on, continues to exist. But I would think that, I've been a dean here at the University of Wollongong now for 8 months and was at ANU previously. What I have experienced is actually great collaboration between the medical schools in terms of being a force to influence politicians and government in terms of their thinking. And Richard, as the CEO of Medical Deans, does a great job there. They're continually sending the same message. We have a problem. There's no one-way solution. You need to look at medical schools and universities differently and really put the money where the biggest bang is, right? If you want to create a rural generalist workforce.
Okay, that's great. Thanks, Zsuzsoka. Look, I think we've set the scene really nicely. We've talked about the kinds of training that's required for rural generalist workforce, the kinds of scenarios that rural generalist doctors might be faced with, the kinds of qualities that are required, the factors in training, selection and training in medical school that would seem to have the highest likelihood of producing medical graduates that might want to be rural generalist doctors. So now I've got a question to throw open to the whole panel, and I'd be interested in your thoughts. So the first is just some thoughts on, so what is the size of the challenge in the workforce that we need in rural areas? So that's my first question. And my second question is going to be, are the current models of care that we have in rural areas also fit for purpose? So do we, is this a two-phase thing? Is it numbers only and then everything will be great? Or are we going to have to look at numbers plus changing up what we do, how we organise ourselves, perhaps how we might fund, you know, postgraduate training, for example, or how we might do end-to-end training, or how we might organise ourselves in multidisciplinary teams and so forth. So 2 questions. So the first is in and around the size of the problem, and the second is numbers alone sufficient to meet to address that? Who would like to start? Charlotte's got a hand up. There we go.
Happy to kick off and happy to have people counter me. I actually think, again, I'll bring it back to this is an Australia-wide problem that we're facing. It's not just a rural generalism problem, and we do need to actually address general practice and generalism if we're going to also solve the rural issue. For me, one of the biggest things is about the culture of medical schools and generalism as the choice of specialty. And I think that, you know, it's a bit, we're sort of addressed a bit with our two deans, but to me, we really, really need to call out the elephant in the room, which is about some of the universities putting down generalism as being, oh, you're too good to be a generalist. You need to be a partialist, and I'll call them partialists because that's how I view them. Because, you know, looking after a bit of you is a really, really important part of medical care in our health system. But actually the most important part is having the generalist there first, because we actually can save a huge amount of money to our healthcare system if we do good generalism first. And generalism is about managing complexity, and, you know, and covering off acute care, preventive care, chronic disease management, and palliative care. And it is a fantastic specialty. And until we sell that in our universities in the first place, that then means we need to transition across into how we sell generalism to our junior doctors. So it's not just about you being in the right place, it's about actually experiencing what general practice is when you are an intern and a junior doctor. And so again, we need to actually have generalism, GP, being a mandatory part, I think, of the first 2 years training of all of our doctors. And if that could be in a rural setting, even better from my perspective. I just think that would be fantastic if we can bring that back in. Then we need flexible funding for what our junior doctors need and want in terms of where they're going for, because it's one size does not fit all. What one junior doctor wants versus what another one does, and going into the future does look different. And so some very much want to be part of an ongoing support of maternity leave, paternity leave, long service leave, etc. So that sort of whole thing of staying within, say, for instance, New South Wales Health as an employee, versus some don't want to have any part of that. They want to be employed as a contractor, and or, you know, what that might look like. So we need flexibility, but we need to make sure that everybody's needs are met so that it doesn't matter how they're employed, that they actually see a really good future in that. And I think Richard sort of addressed that whole thing. We know if you have a sort of a stream of your training going forward, then, and you can plant your family down, then you're more likely to be able to stay. We've got really good stats, can I say, from Notre Dame University. I've got stats of 2/3 of our graduates so far who fellowed, again, we're a baby university, have actually chosen general practice. And of those, a lot of them are in rural setting. It's very exciting data. We're just doing a write-up of it at the moment. And for me, I think that's very much about, well, our graduates are chosen differently from a lot of other medical schools, but two, they are older and they want to be able to plant their families and their lives, and what does that look like? And I think rural generalism is a really good option if it's well supported in the community. So again, it's that whole cultural thing. Sorry, I'll let others speak because I did warn I can get onto a passion
Okay, thanks, Charlotte. Who else would like to jump in there? So we're talking about the size of the problem, and we're talking about some models. We've got some comments in the our chat. I'll address those in a little while as well. Thanks, Richard.
Yeah, look, thanks. It's interesting, isn't it? Look, I'll just make a couple of observations, perhaps that people may not appreciate. Though, I mean, firstly, there's no such thing as the right number of doctors. It's more complicated. It's tied up with, the role the doctors play in the system, etc. And so, there are some counterintuitive things. The fact that we've never had so many GPs, even GPs per head of population, or GP services per head of population. Where we've seen continuous growth, and one might say, well, what's the problem? Why in particular in regional areas or in less salubrious outer suburbs and so on do we see the sort of gaps? Some of it is churn. So the dynamics of the general practice workforce, you've got to understand that, for instance, the majority of the growth of the qualified general practice workforce are internationally trained doctors. And that's fine. They're my colleagues. Our towns have closed down without them, many of my friends, but the evidence there is that growth predominantly ends up in the major cities. And indeed, the substantial proportion of the growth in stock of general practitioners in major cities are international graduates. So that's something that people often don't realise. What's happening, of course, is that we recruit people into regions, often from overseas, often actively, up to 3,000 a year, about as many as we graduate from Australian medical schools. And those folk do great work, but over time end up in major cities and particularly in general practice. And so there's a sort of a revolving door, a leaky bucket, if you will, therefore underscoring the importance of domestic supply. I mean, the most important priority, I'd argue, is that a sufficient supply of domestic graduates pursuing general practice, rural generalist medicine, rural practice, willingly and with enthusiasm is the number one priority, without which this temporary solution that ends up overstocking cities with doctors and driving subspecialisation across and the rest of it, we can never get off the bandwagon. I really like positive approaches. In fact, it's actually the majority of the growth in stock of GPs in non-metropolitan areas are domestic. So actually this stuff that we've been doing works. We just need to do more of it. And I think maybe it's a general point that we need to sort of have an appreciative inquiry approach. Where is it working? How and why? Let's do more of that, rather than the sort of knuckle dragging, rural's doomed, it's all hopeless, where's the coffee, that school is no good, the usual dross. For those of us who've enjoyed enriching and fascinating rural careers and continue to do so, that's bunkum and is unhelpful, because it's a sort of a negative narrative. I think that there's fantastic solutions visible on the ground that you can readily see. I'll pause there.
Okay. No, that's good. Rod, I might just ask for your sort of thoughts. So very interesting. The size of the problem, and are the models adequate?
I guess the size of the problem is probably becoming increasingly difficult to keep a handle on, only because we're seeing dwindling numbers of people wanting to come and do primary care at all, whether it's rural or metropolitan. Numbers seem to be numbers not just seem to be, they are dropping away. And so on a backdrop of an already fairly stressed kind of situation, it's becoming even more challenging at a rate that I didn't ever think that I'd see now that I've got more grey hair. And so I guess the concern is that the concern certainly we have in New South Wales is that we've got lots of people in towns that are not seeing anyone coming through, and the future mentors are going to be gone before the reserves turn up. But before, even if we could train enough, we're often going to be having people go to settings where there's no one a bit more senior help out when things get a bit tricky, or to mentor, those new rural generalists and rural GPs, because they'll have retired ahead of time. I also, I guess I see from our perspective at UNE, one of the great, and I have to say, one of the great disappointments for here is, we've had students well exposed to rural practice for quite a while now, and our return on investment is not coming through. Early on, when we were starting to look at numbers, we talked about, University of New England hazard ratios for coming on as rural generalist trainee were quite good, in terms of people coming on to both Acroman to New South Wales rural generalist training programs. But that now seems to be fading away as well, and lots of the kids that are coming through and training, and even though they might spend a couple of years solid here, there's only a handful that seem to come back because they have, I guess, unfortunately, a lot of the stories that they hear are of how difficult things are, and I have to resist the urge of not going in and saying, don't do medicine, if I'm coming in teaching, final year students crit care. So I guess the stories that they're hearing are becoming, unfortunately, a bit more and more negative over time. The enthusiasm that some kids have when they come and they come and sit in rural general practice and rural generalist practice, and they're in this room for 3 sessions, and they've then got to go and do anaesthetics with me for a couple of sessions and catch a baby to disrupt the day. That isn't translating. They're seeing it, but the evidence gap somewhere is there. Why is it that they're not wanting to be it?
Thanks very much, Rod. And although we've got to remember our positive stories though as well, and I think that's just I think Richard had alluded to that as well. And I just had spent the last 3 days in Mudgee with which is one of our training hubs, and it was a couple of UAW grads there who are now doing obstetrics and ED and general practice, and training our current lot of students through, which means that kind of makes me a medical education grandfather, I guess. But anyway, they were brim full of enthusiasm, and I'm guessing that they're going to be the future of our rural generalists. So I might hand over to Zsuzsoka. Zsuzsoka, some just thoughts on the size of the problem, and a bit of any thoughts on models of care.
Yeah, thanks, Andrew. I'm going to pick up on a few of the comments and questions that were put in the chat and see if I can address at least some of them.
Yes, please do.
What my views are. And so I don't know if everybody's aware, but the GO8 Deans of Health, I think, put out a statement saying we need 1,000 more students per year in medical schools. I'm quite sure that number is quite the right number, but I think there's no doubt. And you just heard, Richard say we bring in as many international medical graduates as we graduate in Australia per year to help us with the workforce. So I think there's no doubt that we have a workforce shortage. But getting to what Charlotte said, the elephant in the room, how students at certain medical schools, wouldn't really say that's everywhere, but what they're being told about being a GP or a generalist. And I'm sure that's not just about becoming a GP or a generalist in general. I've heard lots of particularly female students talk about being discouraged being a surgeon because it's a man's job. So that needs urgent addressing. I don't think that's the case everywhere, and I would think that in those medical schools that have these good outcomes or the focus areas, that would be different. But GPs are specialists too, I don't know why people say, I'm a specialist and then there's the GP. And I think that's the message we need to reinforce. But we need to also be very clear, just picking up on the chat, who trains these students? So not just whom do we bring in and how many do we bring in, and what do we tell them, but who trains them? We cannot continue to expect from a depleted workforce that they train more and more students, right? And the difference between a GP who is in a private practice, and essentially if they teach, they don't make money, as opposed to, let's say, a staff specialist who's employed by a health service. I assume the same would be for visiting medical officer, of other specialties, the same. So we also need to think about the incentives, the opportunities. And what's come up during COVID, particularly with everybody moving out rurally and regionally, GPs are just under the pump. We also need to be aware that 30% of them are over the age of 60. And we're expecting that small, stressed, burnt out, aging, frustrated workforce to train an extra 1,000 students is impossible. So picking up on David Garn's comments, do we have more other specialists, hospitalists who are not GPs trained medical students? Yeah, I'm sure in some areas we do, but because there are more of them and they're in a hospital and they possibly have different incentives to teach. So it's a multi-pronged problem. I also think we need to radically talk about educational evidence and educational changes. As I said, it's not just the same people that we can expect to teach more students. We need to really rethink whether the way we teach medical students nowadays is any different to how it was done, 900 in Bologna or whatever Dr. Flexner told us to do. And whether there are other ways that future health practitioners, and that wouldn't just be the medical students, but possibly nursing and other students, whether they can learn more about health needs out in the communities, wherever their communities are, in different ways.
Okay, great. Thanks, Zsuzsoka. I'm going to just take, Charlotte, I know you want to jump in there, but I'm going to take a couple of questions from some people being very patient in the chat, if that's all right. So certainly got a comment from a very long-term colleague of mine. I won't say how many decades, but it's certainly more than 2, just commenting on, general surgical career, the sort of breadth of scope of things that he had done, including, having GPs doing his, anaesthetics for various things that he'd done over the years, and obstetrics and gynecology and patient care, and talking about a return to rotation of GPs through hospitals and rural practices with, hospital-based specialists and GPs training together at the same time, as a way of, both keeping people training in place successfully, but also, actually working and training together, which is a model that perhaps we've maybe just seen a little bit of a renaissance with some of our rural generalist, training pathways in hospitals. But certainly I think that's an excellent suggestion. So thanks very much for that, Martin. And just we've got a couple of other questions here from folk. Just one of them is in and around whether bonded places have worked. That's just a quick yes or no, Richard or Zsuzsoka, training medical student bonded training places. What's the thought, Richard? Any idea?
Yeah, look, interesting. I think pretty convincingly the answer is probably no, if looked at as an across-the-board intervention. And look, it copped a lot of criticism from the rural sector, unlike the now defunct scholarship model, where you were actually paid. You got a bonus for taking up a sort of a bonded rural place. This is more a conscription model, and wasn't, certainly for a long period of time, attached to any sort of particular support, vocational guidance or anything else. So I think it's been pretty disappointing. That's not to say that return of service has no place. Again, it's this problem of looking at things in a sort of a linear causal way. I think added to the mix, much like a good soup, some level of bonding and incentives is okay, but it can't be the primary driver. And the evidence for that alone is very weak indeed.
Yeah, sure. That's great. And here's a question. Can it be answered in our remaining time? I'm going to say it's not, but just a very quick answer. disparity in financial reward for general practice or MBS items. Do we want to go there? Just very briefly, Rod would like to say something.
I've been controversial before about this, and it's not quite so much that general practitioners aren't paid enough, but trust me, sitting here for the costs in the rooms, it's probably not enough. My argument is that to someone, a junior doctor trying to make a decision about what they're going to do in the future, the attraction to doing specialist training where they could see a patient for 10 minutes and bill $400, there's no competition for that for fine, maybe an extra year or two of work to get in and do the training. So my argument sometimes at AMA level is that maybe specialists get paid too much. As Charlotte said, we're sitting there often doing lots of the filtering, and they get a very well polished, well refined, well investigated patient. So they look incredibly smart when they confirm our initial working, just at quite a substantial different dollar value. And so as I said, a JDoc will look at that and think, why would I go and see 4 or 5 patients an hour when I can see one patient and have none of the other pressures that come back the other way from working in primary care. I couldn't stand doing just one thing all the time, but yeah.
And thanks, Rod. And Rowena, you've been very patient. I'm sorry, Charlotte, you've been very patient. You had your hand up previously. What did you?
Yeah, no, well, I did actually want to talk about the financial part, which is very much, from my perspective, Medicare was designed to solve a problem back in the 70s, which it solved very well, which was about actually accessing everybody to healthcare, and it was actually about equity. Unfortunately now, because of the way in which it sort of failed to be adequately reformed over time with the changes in our health system and what's been happening, it has become a weight around our necks, and done exactly as Rod said. It's this terribly inequitable pay for what you are as a doctor and what services and skills you bring to the table, so that generalism is seen as being the poor man's choice, because you don't get paid nearly as well as you do if you choose another partialist type skill, which is much more highly rewarded. I agree with Richard 100% in terms of the model in which we are paid also under Medicare rewards volume. It does not in any way reward quality care, and we need to actually, I think, put a bomb underneath our system at the moment. I don't think any politician is brave enough to actually really reform our healthcare system, which is a bit sad, really. I understand why they don't want to, but really we need to have a proper reform of the way in which we fund. While we have federal government, paying one part and state paying another part, there's no incentive for the state to in any way also sort of working properly to put in savings to the system, which would actually mean, again, a huge amount of saving in the system, because at the moment there is just, even the hospitals are still rewarded for the more work you do, the better money you generate, rather than actually being rewarded for them doing the best evidence-based care for their communities. And so we need to go back to the evidence. We need to go and look at what else is being done and be brave to reward better, funding models. I really want a mixed model of payment. I don't, and I want to reward continuity of care, which, can I say, in a rural community is a real advantage. It's really easy to prove that you're doing continuity of care. That's where it's really difficult in an urban setting, and to be able to really save costs. I think we could save a lot of money, though, if we made continuity of care part of the model in the cities, and stopping a whole lot of the duplication and extra costs that come out in cities. and then be able to shift that money across into the rural setting and really be able to prioritise some better models of care. Again, I could, go on for it a bit more, but really that is the elephant. And until we really address how that funding looks and how we reward doctors across the system for what your skills are, then we're not going to do it. And I agree with Rod. The opportunity was in the 90s, can I say, to actually bring some equity to everything, and it was the AMA stopped it because there were some people that didn't want that to happen, and we've now ended up with this terrible system where, especially with the loss of bulk billing, we now can't have equity. Where's equity? How do I make sure that the poor, those in the lower socioeconomic demographics and rural and really rural remote areas actually access proper healthcare?
Thanks, Charlotte. Look, we've got a few minutes. We're just going to wrap up. I'm going to run around our panel. Thank you very much for both erudite and passionate contribution to the discussion this afternoon. And thank you for our viewers who've also contributed, and thank everyone for joining in and questions and comments that you've posted. You've a minute each. So the future of rural generalist healthcare. So what are the solutions that we need? I'm going to start with Richard, then Rod, and then Charlotte, and then Zsuzsoka. So you all know what the order is, so that you've got a time to think about it. So a minute. What are the evidence-based solutions that we need? I'm going to start with Richard.
Yeah, look, thanks. So I'll give you this in 60 seconds. Medical deans have been giving this some deep thought, and I think a really important part of this is the question of boosting domestic supply. So we do need additional numbers that we graduate, but deploy that into the regions. So that's so that there's a regional, entirely regionally based push in that. Secondly, this time try and get it right by lining up the next stage, i.e. have the junior doctor posts and intern posts and beyond in the regions, in community and primary care, tooled up and ready to go when that cohort bulge graduates. Thirdly, that we desperately need to invest in the teaching, training and research capacity of the primary care and rural sector. Without that, because it just has so much benefit, it's low-hanging fruit, it's really critical. And then finally, have some regionally based, joined up and connected postgraduate pathway work. So that's sort of, if you like, the regional training hubs plus notion. So they're the 4-point plan, so called. I think it makes a lot of sense. In relation, finally, to the RG, look, I think there are inherent detractors. We know, for instance, the character temperament trait work, high on novelty seeking, low on harm avoidance, get bored easily, love doing it all. Find those people, show them a light on the hill, and they'll beat a path to the job, even if you're paying a pittance. Also pay them well. I'm not saying that, but make it clear that you can have that sort of person and they can see where they're going, because otherwise they'd go nuts. Do the same thing every day work. So I think that's another insight. There are things about safety, quality, etc., that are working against us. There's useful things that we could do in that space, but I'll leave it there. Thanks.
Okay, thanks, Richard. And I'm just wondering whether Richard had been describing you, Rod. So I'm going to lead on to you as the next comment. What else would you add into there?
Look, certainly locally here with our dean here, we're sort of talking about we're talking about cradle to grave care. I think we're getting to the stage where, in part born of frustration, where we're looking at cradle to grave educational pathways, and so it's selecting from before they come into medical school and having it that just about all they can see the whole way through is a rural generalist endpoint or a rural general specialist endpoint, and that our locally grown kids and kids from further west from here can expect to spend much of their training lives in the settings that they want to practice in. And we do need, you know, we do need to have some more evidence-based selection and training pathways, and certainly the kids with that I interviewed for the rural generalist pathway in New South Wales. Typically, when I write on the bottom of their interview script, you know, professional ADHD, they certainly are the ones who that are, you know, tracked towards being the you know, the personality types that have got you know, a tendency that will mean that they'll stay, mean that they won't be afraid of what's put in front of them to have to try and solve. So
that's great. No, thanks. Okay, Charlotte, 1 minute. How are we going to solve this problem?
Look, I'll go a slightly different tack, and just to sort of build on it in a different way, which is that I think we really need to remember that at the moment we're still training doctors for a system that was designed yesterday, with doctors who are burnt out and also working in a model that was done yesterday. And we actually need to be the innovators in actually being able to support our students to be trained into a system that looks completely different. So it means we actually need to also train our students about systems. The moment we still train them as if they are just doctors to deliver acute care. And so they don't understand really about the precious role that we need for doctors across the entire system. And I think we need to then reward the teachers more, which talks about, you know, we can't just take it for granted, and we really need to have more than just a sort of an apprenticeship model. We need it to be much more of a supported, take you through that whole pathway into where it is, which allows it to be more of a personalised, I think, training journey too.
Thanks, Charlotte. That's all right.
Opportunity.
And Zsuzsoka.
Yeah, thank you, Andrew. I'm going to take a different tack now as well. I bet you if we were sitting here and we were, I don't know, oncologists or psychiatrists, which we'd give the same message, but replace general practice, rural and generalists with psychiatrists and oncologists. So I think we need to be, again, very clear that we're not an animal farm here. Not all animals are equal, and not all medical schools are equal, right? So your question was, you know, what research do we need, or what data do we need? So we're now able as medical schools to look at our outcomes. There's been a linkage project that's been done looking at what students wanted when they graduated and where they actually ended up. And I think that is such valuable data to look at each medical school over time separately. So where are the ones that make those rural regional doctors of whatever, not specialty? I think we need to then get the message across to governments that if you want to strengthen the workforce there, these are the medical schools or these are the universities to invest in, if that's your aim, right? And I think the second plea I would make, apart from everything that everybody else said, you know, whom do we get in? But I think our medical education needs Charlotte, you said a bit of a drastic rearrangement. I really think we need to be quite brave and take a step back and really look at how we teach this future workforce. Not just who teaches them, but how they can learn. And I think that would hopefully be one of the puzzle pieces that would put the picture together.
That's great. Look, I'd just like to thank everyone. I'd like to thank our audience. I'd very much like to thank Charlotte and Zsuzsoka, Rod and Richard for contributing their time and wisdom and expertise and experience this afternoon. So we've heard something about the magnitude of the problem and at a more granular level, the clinical problems faced. But I think we've also just heard some real slivers of light there in and around what we know works and training models that we know work, that we have people coming through who clearly are motivated, and we have, you know, generations of rurally trained students who are now doing their work as rural generalists, which is a very bright future. We've got some clear ideas around some funding models, funding changes that are needed, and perhaps that's a bit of where the political lobbying needs to come in to increase the political will for a change in our health system and our funding. And also, as Zsuzsoka said, a bit of a lens on how we fund our medical schools and universities as well. And as Richard had said, look at what's being done well, and just let's do more of the things that are doing well and amplify those success stories. So I'd like to thank everyone today for a very positive contribution, and hope that contributes something to us improving the healthcare for rural Australians. So thanks everyone for joining us.